Hemolytic anemia is defined by a single catastrophic mechanical event, the premature rupturing of peripheral red blood cells. To detect this destruction, the standard medical curriculum focuses on a classic three-part laboratory triad: elevated lactate dehydrogenase, elevated indirect bilirubin, and low haptoglobin. The physiology behind these markers is straightforward. When a red blood cell bursts, it directly spills the enzyme LDH and the pigment bilirubin into the plasma. Simultaneously, the free hemoglobin released by the rupture is immediately bound and cleared by the protein haptoglobin, depleting the body's circulating supply. In a theoretical, isolated environment, tracking the sudden appearance of these intracellular contents and the rapid consumption of binding proteins provides a highly sensitive read on red blood cell survival. Clinical presentations rarely mirror this theoretical precision. Relying strictly on these three values in isolation leads to frequent misdiagnoses, as patients often harbor systemic issues that warp these precise markers. The hemolytic triad is exceptionally vulnerable to distortion from competing physiological signals. Systemic inflammation forces the liver to alter its baseline protein synthesis, flooding the bloodstream with excess binding proteins that mask ongoing consumption. Concurrent hepatic dysfunction impairs the liver's ability to process and excrete waste, obscuring the true rate of bilirubin clearance. And underlying marrow failure uncouples the rate of peripheral cell destruction from the rate of new red cell production. These overlapping conditions routinely cancel out the classic signals of hemolysis, generating false negatives on standard laboratory panels. Accurately diagnosing hemolysis requires setting aside the idealized textbook triad and identifying exactly how these specific clinical states warp the baseline data. Of the three markers, haptoglobin is the single most sensitive indicator of red cell destruction. This vertical slider chart tracks haptoglobin depletion based on the anatomical site of destruction. When cells are destroyed extravascularly, within the spleen or liver, haptoglobin levels drop into the low zone. When destruction happens intravascularly, directly within the circulation, the haptoglobin is consumed so rapidly it becomes completely absent. But haptoglobin's diagnostic utility is complicated by its status as an acute phase reactant. When the body detects systemic inflammation, cytokines like IL-6 stimulate the liver to synthesize massive quantities of haptoglobin. This rapid inflammatory overproduction counteracts the continuous depletion caused by red blood cell breakdown. This can produce a clinical profile where a patient with brisk active hemolysis nonetheless presents with a perfectly normal haptoglobin level on their lab report. If an inflammatory process is present, a normal haptoglobin level cannot definitively rule out hemolysis. LDH serves as a reliable indicator that cells are dying somewhere in the body. The problem is its lack of specificity. LDH is packed into nearly every tissue type, meaning its elevation does not guarantee that the dying cells are peripheral red blood cells. High LDH is frequently driven by ineffective erythropoiesis, where defective red blood cell precursors die inside the bone marrow before they ever reach the bloodstream. Conditions like megaloblastic anemia or myelodysplastic syndromes cause massive LDH spikes entirely through marrow cell death, mimicking the chemical signature of peripheral hemolysis. This brings us to the final component of the triad, indirect bilirubin. This gauge tracks indirect bilirubin, which has a strict quantitative limit. While hemolysis drives this number up, it hits a hard ceiling. An indirect bilirubin level greater than 5 milligrams per deciliter is highly unusual for hemolysis alone. Values exceeding this 5 milligram threshold indicate a mechanical failure of hepatic conjugation or clearance. The liver is no longer processing the pigment as it should. Massive bilirubin elevations demand immediate investigation into concurrent liver disease, rather than assuming a catastrophic rate of red blood cell destruction. The mathematical rule of hemolysis dictates that when peripheral red blood cells are destroyed, the bone marrow must compensate by ramping up production, resulting in an elevated reticulocyte count. Yet clinicians regularly encounter a paradox: patients presenting with active hemolysis, but an absent or inappropriately low reticulocyte count. A low reticulocyte count in the presence of cell destruction isolates the failure directly to the bone marrow's production capacity. Viral pathogens, specifically parvovirus B19, can infect erythroid progenitor cells, inducing acute marrow suppression right in the middle of a hemolytic event. Structural limitations also cause suppression. The massive cell turnover required to replace destroyed red cells rapidly consumes available folate stores. starving the marrow of the raw materials needed for DNA synthesis. Finally, direct marrow infiltration by tumors or fibrotic tissue creates a physical blockade, preventing the release of new reticulocytes, regardless of the peripheral demand. An inappropriately low reticulocyte count does not negate the presence of hemolysis. It upgrades the situation from an isolated hemolytic crisis to a concurrent marrow failure state. When serum markers are obscured by concurrent inflammation or liver disease, urinary evaluation provides the definitive confirmation of intravascular destruction. During acute intravascular hemolysis, the transport proteins are quickly overwhelmed. Free hemoglobin rapidly circulates and spills directly through the glomerular membrane into the renal tubules. The acute diagnostic signature of this event is unambiguous: dark urine coupled with a dipstick that returns powerfully positive for blood. The crucial microscopic caveat confirming the diagnosis lies in the sediment analysis. That positive dipstick will be accompanied by exactly 0 intact red blood cells on microscopy. The machine is detecting dissolved hemoglobin, not whole cells. As an episode of intravascular hemolysis transitions from an acute event to a prolonged state, the physiological processing of that hemoglobin shifts. The renal tubular cells begin absorbing the free hemoglobin from the filtrate. Inside the cells, the iron content is metabolically stripped out and converted into a long-term storage complex. Distinguishing between raw hemoglobin and these processed iron storage complexes in the urine separates an acute vascular crisis from ongoing chronic destruction. Hemosideruria, the shedding of these iron-loaded tubular cells into the urine, is the specific marker of chronic or recurrent intravascular hemolysis. The cellular conversion of raw hemoglobin into hemosiderin by the kidneys is a slow metabolic process. It does not happen instantaneously. This timeline graph illustrates the required diagnostic delay. Hemosideruria takes several days to appear in the urine after the initial intravascular event. Detecting this delayed marker requires a specific step: applying a Prussian blue stain to the urine sediment to illuminate the sloughed iron complexes. The sequence of investigation is rigid. Evaluate the serum markers first for an immediate snapshot, but rely on the urinary sediment to prove the exact chronicity and location of the destruction. The core operational rule for the clinician is to verify the classic triad against the patient's systemic context. Check for inflammation before trusting haptoglobin. Assess liver function before trusting bilirubin. Confirm marrow status before trusting reticulocytes. Mastering the hemolysis workup means recognizing that diagnostic truth lies not in the textbook triad itself, but in accurately mapping the physiological exceptions that distort it.